Okay, everyone, we'll get started. I'm sure more people will log in. So it is good afternoon, everyone. My name is Brett Lindgren. I'm one of the pulmonary critical care faculty, and it's my pleasure to introduce Dr. Toby Maher. Dr. Maher recently joined USC about a year ago in the middle of the COVID pandemic. And through this short time is now the director of our interstitial lung disease program and has helped really advance our ILD conference, which we handle monthly. He's a world leader in interstitial lung disease and IPF. He's headed numerous clinical trials, large volume of publications, and is an outstanding educator. He'll be speaking today regarding developing novel therapies for treatment of pulmonary fibrosis. And feel free to post questions either in the chat or in the Q&A, and we'll be covering them at the end of the talk. All right.
Great. Thanks, Brett. Thank you, everyone, for listening in. Missed my disclosures. Those are my disclosures. So as Brett said, I've joined USC in the last 12 months. It's obviously been an interesting time to change workplace, particularly as I came from the UK. So this is where I was before I came to USC, working at the Royal Brompton Hospital in London. In contrast to the US, we have a lot of history back in the UK. The hospital was built in 1844. So the hospital I worked in was older than the city that I now find myself here in Los Angeles. But it's been a great opportunity to join the faculty here. And I want to describe to you some of the work that I've been doing in the past and which we're now beginning to get up and running here at USC. So realizing that not everybody listening in is a pulmonologist, I'll just give you some background. So when we talk about interstitial lung disease, we're talking about a range of conditions that affect the wall of the alveolus. That is the space that is bounded on one side by the alveolar epithelium and on the other side by the capillary endothelium. And in healthy individuals, that's a virtual space of no more than 10 to 15 microns in diameter. And it really is to allow facilitation of easy transfer of oxygen from the alveolus into the bloodstream and carbon dioxide in the opposite direction. There's a wide range of disorders that can cause abnormalities with that interstitial space, and we can classify those in a number of different ways. But broadly speaking, they can either be inflammatory or fibrotic. And the fibrotic disorders are particularly devastating because they tend to cause irreversible loss of lung function, such that patients develop ultimately respiratory failure. And the commonest of the conditions that we deal with is something called idiopathic pulmonary fibrosis. This tends to be a progressive scarring disorder of the lungs that develops in older adults, usually in their mid-60s. You can perhaps appreciate that this CT scan shows some changes towards the lung bases. And if I just fast forward 18 months in this patient's disease, you don't have to be a thoracic radiologist to see how the lung has now lost its normal architecture and how we've seen replacement of normal lung tissue with this so-called honeycomb air spacing. And this loss of normal lung structure accounts for why our patients develop respiratory failure and die. And although we consider idiopathic pulmonary fibrosis to be a rare disease, in reality, it accounts for 1 in every 100 deaths in countries such as the United States. And therefore, it's not actually that uncommon. This is just showing the same thing, but using histological images. On the left side, we have normal healthy lung with the usual lace-like architecture. On the right side, we see the replacement of that normal alveolar structure with fibrotic tissue, all of this pink stuff. And we see remodeling of the lung with the development of so-called honeycomb air spaces. Importantly, this is a disease with a very bad outcome. The median untreated survival is approximately 3 years from diagnosis. This study here was a study that we ran looking at newly diagnosed patients in the United Kingdom. And essentially, we demonstrated that since the turn of the century and up until the advent of antifibrotic therapy, there really had been little improvement in survival or outcomes for people with this disease. And this slide here just puts IPF in the context of malignancy. if IPF were a cancer, then the 5-year outcomes that we see in our patients are very similar to the more nasty malignancies that we encounter in clinical practice, such as stomach cancer, esophageal cancer, and non-small cell cancer of the lungs. We've come a long way in understanding the pathogenesis. We recognize that there are a number of factors that predispose to patients developing this condition. There's the importance of the environment, and so patients being exposed to factors that cause injury to the alveolus over a lifetime seem to increase risk of developing the disease. We also recognize that there's an important genetic component, and increasingly we recognize that genes related to cellular aging and epithelial integrity and host defense are important in predisposing towards the development of fibrosis. And then we recognize the importance of aging. IPF and other fibrotic lung diseases are really diseases that we see affecting older adults. It's very rare for us to encounter pulmonary fibrosis in someone under the age of 40. Once these factors come together, the disease is characterized by overactivation of pathways involved in the normal wound healing process. This results in an imbalance of pro-fibrotic mediators that in turn activate a range of cell types, but especially the fibroblasts to produce collagen and extracellular matrix. And then this process becomes self-perpetuating. As the lung becomes scarred and stiffer, that in itself is pro-fibrotic and drives the development of further scarring. And importantly, IPF is not the only fibrotic lung disease that we encounter in our clinical practice. It probably accounts for about 25% of the patients I see in my clinic, but we also see important complications of fibrosis in a range of other diseases, including systemic autoimmune diseases such as rheumatoid arthritis or systemic sclerosis. And again, in these patient cohorts, fibrosis is a major cause of morbidity and mortality. And it's worth remembering, particularly for those of you who aren't pulmonologists listening in, that all of the organs in our body are susceptible to the effects of fibrosis, particularly with aging. And increasingly in an aging population, we are seeing problems with cardiac fibrosis causing cardiomyopathy, liver fibrosis, particularly in the context of non-alcoholic steatohepatosis. Renal fibrosis is a manifestation of end-stage renal disease, and myelofibrosis is also a common problem in clinical practice. And interestingly, there do seem to be genetic overlaps between these conditions, particularly as it relates to cellular aging. And so what we learn about pulmonary fibrosis is probably going to be useful in learning how to treat these other diseases. In clinical practice, when we come back to IPF as our exemplar form of pulmonary fibrosis, we do recognize different patterns of disease. We recognize that some patients are rapidly progressive, some patients have more indolent fibrosis, and we also recognize the phenomenon of acute exacerbations, which I'll explain more in a slide or two. This data here was generated in a study that I ran when I was at the Brompton. What we did was give patients a handheld spirometer, so a means of measuring their lung function at home on a daily basis. Every dot on this graph is a daily lung function measure, and this is in a single patient over a year and a half. And you can see that there is day-by-day variability, but you can also appreciate how the disease gets inexorably worse over time. This is another individual with much more rapidly progressive disease who died 220 days into the study. And then here we have a patient who had an acute exacerbation. So you can see that he loses 25% of his lung function over a 14-day period. And what is one of the challenges that we encounter in pulmonary fibrosis is that our patients seem very susceptible to acute lung injury. So an acute exacerbation of pulmonary fibrosis is really an episode of acute lung injury occurring in the context of pre-existing fibrosis. And this series of scans here just illustrates a case we see in practice. So this patient has relatively mild fibrosis affecting the periphery of the lungs. At this point in time, she had a good exercise tolerance. She presented with a 10-day history of rapidly worsening shortness of breath, and you can see now that the lungs have become hazy with what the radiologists call ground glass. And a week later, she's now got lungs that show diffuse damage, and this is really indistinguishable from the sort of ARDS that we would have seen in COVID patients over the last 6 to 9 months. And for reasons that we don't fully understand, our patients with pulmonary fibrosis are susceptible to these events occurring out of the blue in the community. And then this here just illustrates from the same study the average behavior that we see in our IPF patients, that a small proportion are relatively stable over prolonged periods of time, but about 3 times as many are susceptible to rapid decline, and the average patient loses about 10% of FVC over 12 months. Until relatively recently, there was very little we could do for our patients. This here is a patient who's undergone left single lung transplant. This is 5 years after the transplant, and you can see how their native right lung has shrunk down with fibrosis. Until 2014, this was really the only effective treatment we could offer patients. But in 2014, we saw the publication of pivotal trials for not just 1, but 2 antifibrotic drugs. The first of these, pirfenidone, is a small molecule whose mechanism of action we don't fully understand, but in the pivotal trials, it approximately halved the rate of deterioration in lung function over 52 weeks. And then the second drug we have is nintedanib, which is a multi-tyrosine kinase inhibitor, which again showed a similar level of effect in that it halved the rate of decline over 52 weeks. And that was enough for both of these drugs to be approved by the FDA. And 7 years on, we've got the real world data that suggests that slowing FVC decline is important in improving survival in our patients. So these 2 Kaplan-Meier graphs show how survival has improved for patients treated with antifibrotic drugs compared to those who haven't been. However, this graph here is some work that we did with patients who were on long-term pirfenidone following those pivotal trials. And what we did was compare those patients who'd taken pirfenidone for over a decade to age and severity matched patients from a registry in Washington. And what we saw is that those age and severity matched patients had a median survival of about 5 years. That's because patients who went into the original trials tended to have milder disease on average. And what we saw with treatment with pirfenidone was that it appeared to improve survival by about 2.5 years on average, which is quite a spectacular improvement given where we have been up until recently with the treatment of IPF. But the third line on this graph represents survival for the average 67-year-old in the US population. And you can see that even with treatment, our patients with pulmonary fibrosis are losing at least 12 years of life expectancy due to their disease. And so clearly we have a need to develop better and more effective treatments going forward. I'm not going to talk to you about exactly how we develop drugs through different phases. I just put this up to illustrate some of the challenges we have, which is in IPF, we've been very good at running phase 3 trials, but historically we've been very poor at running phase 2 trials. So the sort of small trials that you need to run to give yourself the confidence that you have a drug that might be effective going forward. And if we look at the pulmonary fibrosis literature, we see huge numbers of examples of drugs that have gone directly into phase 3 studies without doing earlier trials that have ultimately failed. And we've been left in the unsatisfactory situation of not knowing why they failed to work, whether the target has been the wrong one, whether the drug has failed to engage the target, or perhaps where the wrong dose of drug has been used. And so a lot of the research that I've been doing for the last decade has focused on biomarkers. And I'm sure you're all aware that biomarkers are any characteristic that can be objectively measured and evaluated and used either as an indicator of normal biological processes, pathogenic processes, predictive of pharmacological responses, or predictive of response to treatment. And there are lots of different ways that we can use biomarkers, either for risk assessment, to facilitate diagnosis, to make some assessment of disease severity, to predict who will get worse in the near to medium term future, to predict who will respond to treatment, or to measure specific treatment responses. And certainly in our field of pulmonary fibrosis, we do have effective diagnostic biomarkers in the form of CT scanning. And we have effective severity biomarkers in terms of lung function, so measures of lung volume and gas transfer. But when we study IPF, we do have the opportunity of measuring biomarkers in lots of different domains. So one of the advantages of studying the lung is that we can perform bronchoscopy, so we can sample the alveolar space directly. We can perform cross-sectional imaging, so we use a lot of CT scanning to help us identify change. And then when it comes to developing blood biomarkers, every minute the whole of our circulating blood volume passes through our lungs, and so it will flush out proteins released from damaged tissue, and therefore the lung is actually a very good place to look for systemic blood biomarkers. One of the studies I've been involved in for the last 10 years has been something called the PROFILE study, and we set this up as a prospective study to try and look for biomarkers in patients with IPF as a way of both better understanding the natural history of the disease, but also to allow us to develop better biomarkers to inform both clinical trial design and clinical practice in the future. And so what we did for this study was recruit newly diagnosed patients with idiopathic pulmonary fibrosis. We followed them for 3 years, and as this schematic demonstrates, we undertook serial assessment at different time points over that 3 years. And when we did, we collected biological samples for biomarker development. We had huge engagement from our patients. They were incredibly enthusiastic in being part of the study. We started recruitment over a decade ago, and we successfully hit our target of recruiting over 600 subjects, and all of them have now completed more than 5 years of follow-up. And it's worth saying that until 2013, we didn't have access to antifibrotic therapy in the UK. So for the first 3 years of this study, it really was a natural history study of untreated disease. And that can be seen in the survival of our cohort. Sadly, the median survival was, as the literature told us, approximately 3 years. As I've already said, the lung is a good place to look for circulating biomarkers. This is a principal component analysis of 130 different proteins measured in the serum of patients with IPF and in healthy controls. And you can see that in age-matched healthy controls, there's very clear separation from the IPF patients, telling us that there are very distinct differences in protein signature. And more importantly, with the blue and the green groups, we see a separation between patients with more stable disease and patients with more progressive disease. And so one of the places we looked first to try and find novel biomarkers was to look for measures of extracellular matrix turnover. Obviously, the cardinal feature of pulmonary fibrosis is this development of extensive scarring in the lungs. And so we worked with a small company in Denmark called Nordic Biosciences, who developed novel markers to look at extracellular matrix proteins that have been cleaved by matrix metalloproteinase. When we started, we compared healthy patients to IPF patients, initially as a sense check to see if we saw differences in these collagen-related proteins in patients with fibrosis compared to healthy controls. And we started off with 11 analytes, and we weeded those down to 8 key analytes that appeared to be different between healthy and disease. Once we did that, we then looked at the longitudinal behavior of these biomarkers. So to orient you to this graph, this is collagen 1 degraded by matrix metalloproteinase. The green is the levels in healthy age-matched controls, and the red and the blue are patients with IPF, with the red patients being the ones whose disease was most rapidly progressive over the first 52 weeks of the study. And so you can see with this marker that levels are elevated in IPF and that they continue to rise in patients with disease that is getting worse. And this is a pattern that we saw with several of these markers very consistently over time. So the next thing we wanted to do was to see if that change over time was prognostic. So just to illustrate what we did next, if you imagine 2 hypothetical patients, one with increasing levels, one with stable levels in our biomarker over time, you would expect that if the biomarker changing is predictive of outcome, that if you take those patients with increasing levels, they'll have different survival and life expectancy compared to those with stable levels. And indeed, that was what we saw with 5 out of these 8 markers, that patients with rising levels over time very clearly had a worse prognosis than patients who had stable levels over 6 months. And importantly with this, I'm not going to talk you through this table, but the take-home message is that actually the change in the biomarkers was informative within 3 months. And the traditional measures that we use in our clinical practice, particularly lung function measures, often take a year before they tell us whether patients are genuinely getting worse or not. We've subsequently gone on to look at other markers. So we've looked at markers of collagen synthesis, and these are similarly informative to the markers of collagen degradation. We've also then separately looked at measures of alveolar epithelial cell damage. And interestingly, some of these markers, CA125 and CA199, are things that have long been considered to be tumor biomarkers. And in actual fact, these are proteins that are found in epithelial cells, and the reason that they function well is as tumor biomarkers is because most of our tumors are epithelial derived. But in IPF, we see this huge change in the epithelium in the lung, and correspondingly, we see this increase in biomarkers related to epithelial cell turnover and death. And interestingly, one of our most informative biomarkers has been CA125, where we see that short-term change over 3 months strongly predicts survival. And then we've also more recently looked at another epithelial marker, CYFRA21-1, which is a cytokeratin protein. And again, this gives us a very clear signal in terms of identifying those patients with poor prognosis disease. So it's all very well noticing what happens to these proteins as disease gets worse. But the next question we wanted to try and answer was whether any of our treatments have an effect on these changes in biomarkers. Can we use them as markers of treatment response? And so working with the manufacturers of nintedanib, we developed this trial where we took patients with mild pulmonary fibrosis and we randomized them to receive nintedanib or placebo for 3 months in a blinded fashion. And then at the end of 3 months, all patients went on to open label therapy and continued on it to the end of study at 52 weeks. And in doing that, we hope to see whether any of these blood biomarkers changed over the short term with treatment. As we would expect, we saw a difference between groups in terms of forced vital capacity. That's the lung function measure we use in our phase 3 trials. The biomarker that we chose as our primary endpoint, CRPM, which is C-reactive protein degraded by matrix metalloproteinase, didn't actually change with treatment. This was one of the markers that gave us our strongest prognostic signal, but it doesn't seem to be a marker of treatment response. By contrast, you can see with CA125 that we get a very robust 25 to 30% reduction in CA125 levels following treatment. And just to remind you, the dark blue line are the patients who received blinded nintedanib for the first 3 months, and you see this reduction in CA125 levels. The pale blue received placebo initially, and then at 12 weeks went on to open label nintedanib, and you see this corresponding reduction in CA125 levels that mirrors what we saw in the initial active treatment group. And then another one that we looked at was C3M. This is collagen 3 degraded by matrix metalloproteinase. And again, we see this reduction, albeit over a much longer time period. So CA125 seems to give a treatment signal within 4 weeks. C3M seems to require at least 12 weeks of therapy before we see significant changes in levels. Moving away from blood biomarkers, other developments that we've seen have been around genetics. So this is work that was led by David Schwartz's group in Denver. And this was a very large-scale GWAS study performed in patients with IPF. And this has been pivotal to our understanding of the role of genetics in idiopathic pulmonary fibrosis. Increasingly, we recognize that there are some common variants that have a relatively small risk effect, whilst there are some rarer variants, particularly those affecting surfactant proteins and telomere-related genes that have a high effect size. And interestingly, there's already been work to suggest that these different genetic polymorphisms may predict different outcomes to therapy. In the case of this study that was published by Justin Oldham's group up at UC Davies, they showed differential effects to the antioxidant N-acetylcysteine based on TOLIP genotype. We've also done work looking at blood transcriptomics. So although IPF may appear to be a lung-focused disease, we see changes in the transcriptomic profile of circulating monocytes and lymphocytes. And we can use whole blood transcriptomic profile to identify patients who have a poorer prognosis. And this is work that we performed in collaboration with Naftali Kaminsky's group in Yale, showing that this transcriptomic signature made up of approximately 51 genes robustly identifies a poor prognostic group of patients and does so across 6 different cohorts internationally. And importantly, early data would suggest that this signal changes with therapy. Other work that we've performed has looked more specifically at the circulating monocyte. And importantly, we see that the circulating monocyte is the key cell that translocates from the circulation into the lung to become an alveolar macrophage. And increasingly, that becomes important in older age. And we see an exaggerated role for circulating monocytes in patients with idiopathic pulmonary fibrosis. And importantly, we see phenotypic differences in these circulating monocytes as they translocate into the lung. And we can use the cell surface profile of those monocytes again to identify individuals at risk of poorer prognosis. Work here done by Pavesh Khatri's group at Stanford, published a couple of years ago now, also shows that you can use something as simple as the circulating monocyte count to identify poor prognosis patients. So you don't need to do clever flow cytometry. You can actually simply rely on the complete blood count and look at the level of circulating monocytes to identify patients at high risk of poor outcomes. And importantly, Pavesh and his group showed that this isn't just true of idiopathic pulmonary fibrosis, it's true in systemic sclerosis and in other forms of end organ fibrosis. And again, this is something that we've replicated in other cohorts and published on recently. There's also been interest in the role of the microbiome in the IPF lung. So of course, a lot of the work that's been done on the microbiome has been done by the gastroenterologist looking at changes in the GI tract. But increasingly, we recognize that in lung disease, change in the lung microbiome in itself seems to be predictive of poor outcome. So when we look at lavage fluid from IPF patients, we see much higher bacterial loads compared to patients with COPD or healthy age-matched controls. And importantly, we see that bacterial load in itself seems to predict poor outcomes. The higher your baseline bacterial load in IPF, the more likely you are to die in the short to medium term. And importantly, that relates back to the genetics. One of the common polymorphisms in the MUC5B gene, one of the surfactant genes, predicts bacterial load, somehow therefore relating host genotype back to phenotype. And again, we've done some work trying to integrate this with radiology. And perhaps more importantly, there's work ongoing to try and use AI-based approaches to better interpret changes in chest imaging. I've already shown you this sequence where there's a very clear change in fibrosis over time. We're now trying to use computer-based algorithms to better identify more subtle change in imaging to try and give us complementary information over and above that we receive from either blood biomarkers or physiological-based biomarkers. And there's already data suggesting that we can use imaging data to predict prognosis, both at baseline and when we look at short-term change in serial images. And so now there's a lot of work ongoing to try and integrate all of this data. And I think this is common to work that we see in oncology and in other forms of organ disease, where there's an attempt to better fingerprint diseases to use the integration of genomics, transcriptomics, proteomics, and radiomics, for instance, to try and better understand both what causes disease, but also what it is that drives disease worsening and outcomes. So now in the last bit of my talk, I'm just going to pivot to look at how this data has been useful in working to develop new drugs for treating pulmonary fibrosis and other forms of fibrosis. So the first study that I'm going to show you is just an early example of a design that we adopted to try and find early proof of concept that perceived anti-fibrotic drugs might actually be effective in the clinic. So this was a study run using an autotaxin inhibitor. And what we did was dose patients for 3 months, perform bronchoscopy at baseline and at 3 months, and also follow lung function over time. And what we were able to show with this study design was that the drug did what we expected it to. The autotaxin inhibition downregulated downstream proteins in this pathway, the lipophosphatidic acid compounds. So we showed the drug did what we expected it to, and it did so in a dose-dependent manner. But importantly, we also showed this effect on lung function over 3 months. That led on to a phase 3 trial. Unfortunately, this had to be terminated early because of emerging safety signals and interactions with the existing drugs. Building on that trial design, however, we did work with a PI3 kinase mTOR inhibitor, where there was good preclinical evidence that PI3 kinase plays a role in the development of fibrosis, and inhibition of the pathway appears to be anti-fibrotic in vivo and in vitro. And we developed an adaptive study, again, where we used bronchoscopy before and after treatment, but where we also introduced FDG PET scanning to look at metabolic activity within the fibrotic lung. And the adaptive component of the study was to allow us to dose escalate or de-escalate based in what we saw in each individual cohort. So we were able to use the data derived from the first cohort to make decisions about how we would modify the dose in the second cohort to try and maximize the effectiveness of the drug. With this design and with the repeat bronchoscopies, we were able to sample airway inflammatory cells and look at changes in phosphorylation of key proteins in the PI3 kinase pathway, in particular phospho-AKT and phospho-PIP3. Doing that was able to show us that oral dosing with an inhibitor had an impact on the alveolar space. So the drug was penetrating the region of the lung where we wanted to see treatment effect. And we saw a dose-dependent effect on phosphorylation of proteins. We also saw, importantly, a dose-dependent effect on lung metabolism. We know that fibrotic regions of the IPF lung are hypermetabolic, and we were able to show reduction in that with treatment. Importantly, we were able to use some of the blood biomarkers that we developed, particularly the collagen synthesis biomarkers, to show that there was a clear dose-dependent reduction in these. So pro-C6, pro-collagen 6, you can see a dose-dependent reduction compared to the placebo arm, and similarly in pro-collagen 3. So all speaking to a potential anti-fibrotic effect for this drug. We've also looked at the potential for delivering drugs by inhalation. So we're trying to get away from some of the systemic side effects that oral or parenteral dosing of drugs can cause, and taking advantage of the fact that it is possible to dose the lung topically through inhalation. And so we first of all developed a proof of concept study using radio-labeled salbutamol, not because we thought salbutamol would be an effective treatment, but because we know well its pharmacodynamic characteristics, and it was a model drug to allow us to study the potential for giving inhaled treatments to IPF. And we were able to show that it is feasible to deliver inhaled drug to the fibrotic lung as long as we get the particle size right. But we did show that fibrosis and severity of fibrosis has an impact on inhalation. So this is important data to take into account when trying to design inhaled drugs for IPF. But following on from that, we took an active substance targeting alpha V beta 6. So alpha V beta 6 is an integrin that activates TGF beta. TGF beta is a major profibrotic cytokine. And we delivered this alpha V beta 6 inhibitor by inhalation. And we used PET scanning with a very specific PET ligand to alpha V beta 6 to show that administering the inhaled drug displaced the PET ligand. And again, we were able to show that it was possible to effectively deliver drug by inhalation to patients with idiopathic pulmonary fibrosis. And that subsequently led on to another trial using an inhaled therapy, this time targeting galectin-3. Galectin-3 is a macrophage activating protein that again appears to be important in the development of fibrosis. We used a similar adaptive design, again with repeat bronchoscopy. And in this study, we were able to show that the drug had a pharmacodynamic effect. It downregulated surface expression of galectin-3 in alveolar macrophages, but it also had an effect on circulating biomarkers of fibrosis, in this case, YKL-40 and PI1. And these studies have been important because one of the challenges we have in pulmonary fibrosis is that there are multiple different pathways that we can hope to interact with to try and modulate outcomes for patients with pulmonary fibrosis. This schematic is just trying to model the pathogenesis of disease and points out the key features we see as important: injury to the epithelium, activation of macrophages, activation of clotting cascades, proliferation of fibroblasts with production of collagen extracellular matrix, and damage to the endothelium. And all of these drugs and pathways mentioned on here are pathways that are currently being studied in clinical trials for pulmonary fibrosis and other fibrotic diseases at present. And it's important that we develop better strategies for running proof of concept studies so that we can select out the treatments most likely to be effective in patients and which are therefore most important to take forward into phase 3 studies. And just thinking very briefly to the future, probably we're going to move to combination treatment studies in the future. We already have 2 antifibrotic drugs. We have done some trials combining them, showing that the 2 drugs together are better than the 1 drug alone. But one of the challenges we have with our current treatments are that the side effect profile, particularly when used in combination, makes it difficult for patients to tolerate long-term therapy. Importantly, as I've already told you, IPF is only one of many fibrotic lung diseases. So we've recently seen that our antifibrotic drugs work not just in IPF, they work in all different diseases that cause scarring of the lung. And we've looked across broad groups. We've also looked specifically in individual diseases such as systemic sclerosis. And then if you go into the preclinical literature, you can see that there is evidence that these antifibrotic drugs probably work in other organ fibrosis. So this is an example of a preclinical study in a mouse model of cardiac fibrosis, showing that pirfenidone, one of our 2 antifibrotic drugs for IPF, appears to have an important effect in modifying the development of cardiac fibrosis. And again, there are now phase 2 and phase 3 trials being done to test the role of pirfenidone both in cardiac fibrosis and in renal fibrosis. So what we learn from our pulmonary experience may be important in other disease areas. So really, just to summarize what I've shown you, I've talked you through pulmonary fibrosis and explained why I think it's an important disease, not just from a pulmonology perspective, but also because it's a model disease for end organ fibrosis in an aging population. I've shown you that we've got antifibrotic drugs that work, so we know it is possible to target fibrosis and at least slow the development and progression of the condition. I've shown you that it's been possible to identify biomarkers of fibrosis, and although we need better validation of those, they are beginning to feed into our use in clinical trials, and I'm optimistic that with the right studies going forward, we're going to be able to use them in clinical practice. And again, what is true of pulmonary fibrosis may well be true of other forms of fibrosis. And so I'd like to think that what I've spoken to you today about is not just important to me as a pulmonologist, but actually is important across all of the organ-based specialties that we deal with here at USC. So obviously a lot of people helped in this work. This was my team back in London. This is a longer list of names of people who've been involved. It's not exhaustive, and I've undoubtedly forgotten people. And already 9 months in at USC, I've had a lot of help and assistance from people here in getting things up and running. And hopefully it will be possible to get these studies going much more effectively now that we're getting past COVID. And if anyone wants to collaborate on fibrosis-based studies, I'm always very happy to talk. Thank you.
That's great, Toby. Does anyone have any questions? I think I muted everyone, so you can either type or ask questions in the chat. There's one that says, Dr. Maher says, how can we refer our patients for participation in these studies?
So either you can email me or contact me directly, or our research nursing team within pulmonary critical care medicine, which is led by Lynn Fukushima, who's been great at helping me get trials up and running. And it's worth saying that we've already got 3 clinical trials running and hope to have more going soon. So if people have patients, feel free to talk.
Another question is, has anyone, hold on, chat's good. Has anyone thought of using nintedanib or pirfenidone in inhaled form, since there is a oral side effect profile?
So yeah, the short answer is yes. So there's been a small phase 2 trial looking at inhaled pirfenidone, which suggested that it may well be effective by the inhaled route. And there's a company who are trying to get funding to do a larger phase 3 study. There are also several companies exploring the possibility of developing inhaled nintedanib. At the moment, we've been limited by the exclusivity held by Boehringer, but that's going to run out soon. So I think there'll be the opportunity to develop it by inhalation. And I'm certainly aware of several generic companies, particularly in India, who are already working to develop inhaled formulations. I guess the challenge will be doing clinical trials to show efficacy.
And there's a question is current use of immunosuppression or biologics a contraindication to study participation?
So yeah, and what I didn't touch on is that the role of immunosuppression and biologics in fibrotic lung disease is challenging. So in idiopathic pulmonary fibrosis, for instance, we know that using immunosuppression, particularly high doses of corticosteroids, can actually be harmful to patients. Whereas by contrast, in patients with systemic sclerosis, we've now got good evidence that drugs like mycophenolate and tocilizumab are actually important in changing disease outcomes and modifying the development of fibrosis. So the first part of the question is we wouldn't always want to use immunosuppression. We would use it in very specific circumstances. However, within that context, most of the trials that are coming along for diseases like systemic sclerosis or for the broader range of pulmonary fibrotic diseases are allowing patients to be on background immunosuppression.
You talked about a lot of biomarkers, Toby, but are there any lab tests that we could send that are easy to come back, that we could trend over time, that may predict progression or risk of acute exacerbation?
So we haven't quite reached that point. And I think CA125 certainly has the potential to be that sort of biomarker. You know, as I've tried to do the work to validate them, I've spent a lot of time sort of reading the literature, looking at other disease areas. And obviously in prostate cancer with PSA, for instance, there's a lot of literature showing that slope of change is very important in predicting changes in prostate cancer and driving treatment decisions. And so my vision for the future is that CA125, or perhaps one of the other proteins that I mentioned, will be something that we can measure to use increases and decreases to help us guide therapy. But as of today, because we don't have enough information from our studies, it's probably not something that we should be measuring, because I'm still not sure how best we can use it to inform clinical practice. So I think we're close to being able to do it, but not quite yet.
Any other questions or comments? Okay, that was great. Thank you very much, Dr. Maher.
That's a pleasure. Well, thanks everyone for dialing in, and thanks Brett for hosting it, and see you all.
Thank you, Dr. Maher.
Thank you so much.